It is very well established on solid and sound international evidence with large sample size that children affected by HIV are not reaching their developmental potential.
The term the economists use is pay now or pay more later. So we need to act with alacrity in order to help these kids get back on a normal developmental trajectory.
There's increasing evidence on what we need to do. There's absolutely conclusive evidence on what happens if we don't do it.
And it really is the call to say we have to, there's a kind of moral obligation to do something about this, because it does work, it can be done, it is feasible.
I was affected by HIV. My parents, my father was a soldier. He came back from the war, and then suddenly after a short time he started falling sick on and off. My mom was expecting a baby. The grandparents at that time, stigmatization was too much, because they felt that if you touched anybody with HIV, you would definitely get HIV. So they also rejected us. Life, when you have been affected by HIV/AIDS, is not a good one. You are denied so many things. After my father passed on, we shifted from the shack to the home, the HIV patient's home. And that's where our mother left us. I was 9 and she died when I was 11, 12 years. I stayed behind with my young brother who was also infected. That's when the caring community came into our lives.
155,000 new adult HIV infections occur every day. There isn't a population of affected children. Present and future children are affected in an ongoing and cumulative way as we speak. And these effects have occurred over 3 generations and will persist in occurring probably for the next 3. And it's something you'll hear from Chris as well. Just the size, the sheer size of this problem and the nature of its moving target. It is not a sense that there is a group of children that today we need to go out and reach. That group is growing all the time.
These experiences get under the skin. They get into our bodies through their impact on the brain, and they can have profound effects on health and HIV in particular. These long-term health consequences are also associated with physical violence, emotional abuse and neglect, not just sexual violence. That those factors can also contribute to risk factors for HIV, such as drug use and other risky sexual behaviors. And the evidence is very strong for this connection.
The vast majority of kids who've never been in an institution, 70% or more, have a secure attachment. In contrast, only a fraction of the kids who start life in an institution have a secure attachment.
It's very clear that 2 things will happen if we do not expand economic strengthening, financial support and psychosocial care, that there will be 2 inevitable knock-on effects. The first is that among the most vulnerable children we will see increased HIV infection rates, and the second is that amongst HIV infected children we're going to see reduced treatment adherence.
That in spite of all the bad news and how terrible it is, and it is, I can uplift you by telling you there's really a lot of hope. There are things we can do that many kids do survive and do well.
Children have to become an integral part of the adult response. Family-based, home-based services make sense for supporting the earliest testing of children, getting them onto treatment, getting support to their parents as early as possible, supporting their parents' adherence so they don't become ill, and providing assistance to the family as a whole.
But once you have high levels of treatment to make the difference even more so, even to get us closer to the no HIV scenario, you have to have much higher levels of adherence.
And the best study that I've seen of adherence in sub-Saharan Africa had 4 countries in it and showed that at 6 months adherence was 20% and at 2 years adherence was 7% amongst adolescents. If we don't pay attention to adherence, we're not going to, there's absolutely no way that our treatment approaches are going to work.
Very clear synergistic relationship here between supporting better outcomes for adherence and better outcomes for the child, and as a byproduct you have a healthier mother, which also has better impacts for the child. You're looking at doing economic strengthening perhaps with the household, perhaps support to mothers or women who are suffering from mental health problems, support with other stresses in life, all of which would also strengthen the household for children.
The evidence also shows that if you can add that in, if you can add in cash and psychosocial care, you get very, very clear returns. What we seem to have is a multiplicative benefit of particular combinations of interventions. And we really started off looking at the benefit of cash transfers, not just cash transfers, but school feeding and food gardening, and to say, what benefit do we get from that in HIV risk? And we found in HIV risk we get benefits really specifically for girls. We then started looking wider at what happened when we included psychosocial care. And psychosocial care was particularly positive parenting and parental monitoring and teacher support. And what we got was an enormous benefit. We found that not only for girls did it work, for girls it worked on multiple outcomes, but also for boys. And when we looked beyond, and we've just started to do these analyses, when we looked beyond HIV, we also found reductions in crime for boys, we found reductions in pregnancy for girls, we found reductions in school dropout for boys and for girls.
So what are the implications of all that we've talked about? You've got 35% of children, you have to find ways in which to have large-scale programs in order to reduce risk. But the outcomes of that risk tend to be concentrated and clustered and in smaller groups. And we haven't had the interventions which are intensive enough to respond to a child who's experiencing a very negative outcome. We tend to have medium-sized programs which are not intensive enough to respond to the depth of the problem for the children who need it most. So maternal infection, illness, and transition to treatment or death occur mainly in the first decade of life. Yet we've tended to focus on older children. Perhaps we need to have greater focus on affected families with young children. And so opportunity is clearly there for combined adherence and family support, and as I say, that would have the double benefit of keeping caregivers healthy and also providing the same types of support that the household needs in order to keep the child protected.
Yes, I went to school up to the university. I passed through the secondary and university. I graduated in Bachelor of Arts in Education. I'm a teacher by profession. I started working, I gave back to the community.